Assalamu alaikum. The short clinical station day. The first scenario will be a neurological examination. Please examine the lower limb of Mr. John Smith. He is 18 years old. Dr. Muhammad, you saw the patient,
Yes,
the
yes,
foot in
yes.
the chart box.
في picture?
Yes. Yeah. There is a picture. I shared it already just now. Here it is. You can start now.
Good morning, Dr. Muhammad. I will see the wall with the case and wash my hand and go to the patient. I will tell I'm Dr. Muhammad. I'm best candidate. I will examine you. If any pain, anytime, tell me. I will stop if you don't mind. Okay.
Okay, doctor.
Start by around. There is walking aid. I will see the picture. يعني not clear. There is, I think, left leg. There is muscle bulk not يعني في some atrophy. Okay. I will start by tone. How is the tone? I will make around the knee and circumduction and shifting. How is the tone?
Tone is normal.
Then I will do the power. I will make him elevate both limb up. Any drift?
Yeah, the power is reduced.
Okay. Around the hip abduction and adduction, what is more?
Yeah, the power is 3 over 5. The proximal.
3/5. Okay.
Yeah, proximal to
around the knee also?
Yeah, the same thing.
Okay. About reflexes on the knee and ankle, how is the reflexes?
Reflexes are absent.
You will tell him to clench his teeth to reinforce the same.
Yeah, absent.
Okay. I will start to do no need to plantar down going, right?
Plantar upgoing.
Plantar upgoing.
Mm.
Okay. And ankle jerk. Clonus, any clonus?
No clonus.
Okay. I'll start sensory by pinprick all dermatome from foot up to the knee, right and left side.
Pinprick is normal.
Pinprick is normal. Fine touch is the same.
Normal.
Bilateral the same. I will compare with the head. With the
normal.
Okay.
Normal.
About joint position.
Impaired.
Impaired. Impaired up to which level? I will start by finger
up to the knee. In fact, up to the knee, it's still impaired.
The knee. Okay. What about? I will tell him to, if he can, to do coordination, to put his right foot on the chin and do coordination to test the coordination.
It's jerky. He couldn't do it very well.
He can't do it?
Yeah.
Okay.
Yeah. Can't do it. Okay. It's jerky. It's not straight. It's absent. Yeah.
Okay. About also vibration test from the finger up, the same level of the
vibration too is absent.
Okay. I will take a permission to do to make the patient walk if can be.
Doctor, I can't walk, doctor.
Okay. There is time?
Yeah, there is 2 minutes.
Okay. There is base cafes there because not clear. There is base cafes there?
Yes, there's base cafes. Yeah.
Okay. I will take a permission to do the other cerebellar signs from the examiner, if we can do finger, nose, and this the endokinesia and then stigmas.
Okay. Positive. There are cerebellar signs.
cerebellar sign positive, right? Okay. I will ask also any scars anywhere in the back of the neck.
No scars, doctor.
About the any pinprick for diabetes in the fingers.
No, doctor.
Okay.
1 minute left.
Okay. طبعا دكتور باسم يعني it usually take time يعني it is not like this.
Yes, of course, of course.
يعني I should give the order and wait a minute for it.
You can, yes, if you want to repeat something, if you want to do another signs in the hand examination, you can offer whatever you want if you have time. And the examiner will tell you no need or skip, also
Yes.
according to the case. If
I
you
will
are
do
done, okay.
huh?
Yes, continue. What you want to do before we finish?
In the hand, the same sensory and sensory deficit, the same posterior column, the same.
You will offer, and the examiner will tell Dr.
Yes.
Henry.
No, don't bother. Don't bother. Don't do it.
No need. Okay. Okay. It's 8764. Time is up. Continue the questions now.
Can you present your positive findings in this patient?
I examined this gentleman, 80 years old, was by inspection there is
18 years.
18 years old. Yes, by inspection there is walking aid there. There is by doing examination, notice the bulk of muscles bilateral is also by inspection is low, especially distally, and there is loss of the there is myopathy weakness, also more distally, and loss of the dorsal column sensation up to the knee level. There is bis cavus, and there is cerebellar symptoms there. I want to ask for Romberg sign, but he can't walk. Okay.
Okay. So, what's the likely diagnosis?
Most likely diagnosis by this age, Charcot Marie tooth, hereditary sensory motor. Also, I can add many causes, alcohol, and also subacute combined degeneration. But because of there is base cavus, there is maybe long time. So Charcot Marie is my first diagnosis, and
Hello?
Dr. Muhammad, describe the lesion. What do you think the lesion is there?
lower motor neuron lesion with posterior column affection. For differential diagnosis.
Dr. Mohammed, what was the extensor-plantar response in this patient?
Plantar response, it was upgoing, positive upgoing.
Upgoing. So upgoing, is it lower motor or upper motor?
Oh, sorry. Yes. Spastic paraparesis. Yes, sorry. Spastic paraparesis. There is upper motor spastic paraparesis with dorsal column affection. So the differential will be.
What is the deep tendon reflex here? The deep tendon reflex in the ankle and the knee. What was it? What did you get?
Normal. It is normal. Equivocal because I do the reinforcement and it is still
absent. Okay, good. Okay, so there's pes cavus, right? And the sensation, the dorsal column is impaired, right? While the fine touch and crude touch are intact. So do you want to reconsider your diagnosis again with presence of cerebellar sign? Do you want to rearrange your diagnosis? Hello?
Okay, give him some time to think. Maybe he's trying to collect the thoughts.
Just okay.
So Muhammad, try again to remember and to recall what the patient was having and to link together. Link the finding together and try to get a diagnosis.
We now have one of the upper motor is the upgoing plantar and generalized weakness and posterior column affection. The cerebellar I can't do.
You did the
So-
coordination.
You
And
did
he told you,
coordination,
yeah.
Ah,
He
yes,
was-
yes.
Yeah.
I
So what
thought
do
I
you
heard
think?
he can't do. So cerebellar is there. I will ask, I need to hear his speech. If ataxic also, it will be Friedreich's ataxia. First one. Subacute combined degeneration second.
Okay.
MS.
lovely. Okay, good one. Okay, so then how will you investigate this patient? Dr. Muhammad.
Investigation by history first. I need to take the history of the patient, and I will do nerve conduction velocity, and I will send for vitamin B, thyroid, genetic testing. Um, also brain MRI and spinal cord MRI.
Okay.
Still,
Okay.
the diagnosis is not there. LB for also electoral band for MS.
Okay. All right. How will you manage this patient?
Non-pharmacological by disease counseling, education, sharing the occupational therapy and physiotherapy and social to help him for any support. And according to the diagnosis, Friedreich ataxia, this mostly it will be supportive. Other, if there is vitamin B, it will be support by IV vitamin B. MS, it will be by according if there is flare, it will be by steroid and steroid sparing agent or monoclonal. Okay.
Okay. All right. Dr. Mohammed, I want to ask you some questions. What are the causes of absent deep tendon reflex and positive extensor plantar response?
I see it in subacute combined degeneration.
One.
And some toxicities can be
Toxicity
like cyanide, like it, like this.
no. What else? No. Any other one? Okay. The next question I want to ask you again is, okay, what are the causes of bilateral pes cavus? Examiner's questions.
The Friedrichs Charcot Marie Twist, sensorimotor, and tropical and hereditary causes.
Tropical hereditary what? Sorry.
Hereditary and tropical spastic paraparesis.
Okay. Then what are the causes of unilateral pes cavus?
Unilateral pes cavus. It will be long-term stroke after spastic stage will be also after there is a sensory level preservation after trauma or tumor disc of the and cause sensory level preservation but long-term complication.
Okay, what else? Okay.
If there is
okay. Since your diagnosis is Friedreich ataxia, what is the mode of inheritance of Friedreich ataxia?
It is autosomal dominant. That's why the genetic testing counseling is very important in this case.
Are you sure, Dr. Mohammed?
Not dominant? I'm not sure.
Are you sure?
I'm not
Okay.
sure.
Okay. Actually, is okay. Okay. Then, what's the gene that I want to test for this patient? You mentioned genetic testing. Which gene are you looking for?
Mm,
Which gene are you looking for, Dr. Mohammed?
I'm trying to remember. Oh, I don't remember.
Okay. So the last question, okay, the second to the last question. Is function ataxia a trinucleotide repeat sequence condition?
So is yes, trinucleotide. Yes, there
Okay.
is generation
Okay.
anticipation.
Okay. Does it undergo anticipation?
No, not good participation. Anticipation.
Okay, doesn't. Okay. Which other trinucleotide sequence mutation do you know outside Friedreich ataxia?
Huntington chorea also. The
Good.
same.
What else? What else?
What else?
Okay. Thank you very much. I don't want to waste our time. You've done well, Dr. Mohammed. That's a good one. Dr. Mohammed, can I comment?
Dr. Henry, I will ask him one question, okay?
Okay. All right. Sorry.
Sorry.
Look,
Okay.
Dr. Bassem, first time to do that short clinical
It's
like this.
okay,
Usually
Dr.
do live.
Muhammad. No. It's okay. Just relax. One question only. You said multiple sclerosis, right?
Yes.
Okay. What with and what against multiple sclerosis, or how? What is the situation can fit this case with multiple sclerosis? It's an easy question. Why you can or why it could be correct?
We have upgoing plantar, and this is going with upper motor neuron lesion, and this is positive with MS. What against and what also there is sensory loss. But against
Okay. The question by another way. What is the only situation you have lower motor neuron lesion along with upper motor neuron lesion in multiple sclerosis? There is only one situation you will have hypotonia, hyporeflexia, although the MS is upper motor neuron lesion.
with peripheral neuropathy.
Okay, it's as occasion, it can happen, but it's very rare. There is another occasion which is more common, and it might be presented well.
Yeah.
Okay. It's very important, by the way, and very common question in the exam. MS can present with lower motor neuron lesion, hypotonia, hyporeflexia. What is this situation? You're done? So,
Yes, yes.
Dr. Henry can answer this question, Dr.
Yeah,
Henry?
cerebellum. Once it's affected the
Perfect.
cerebellum, it can cause that.
Yeah. Whenever the cerebellar affected with multiple sclerosis, you will have hypotonia, hyporeflexia as lower motor neuron lesion, although the MS is upper motor neuron lesion. Okay. Okay.
And
Thank you,
this
Dr. Yeah.
is صح؟ There is cerebellar here. صح؟
There is cerebellar, yes, but it fit more as Dr. Henry will explain now. It fit with Friedreich ataxia as there is peripheral neuropathy, which is not present in the multiple sclerosis. It's less to be a patient will be unlucky to have diabetes, for example, with peripheral neuropathy. So it's like occasion to have peripheral neuropathy along with multiple sclerosis, upper motor neuron
It
lesion.
is there, Dr. Bassem. It is there. I have seen this case. It is there. Diabetes
No, no,
and
no. Yeah. Okay. As occasion, yes, but it's not common. Okay. Yeah, it's there. You can have it, but it's not common. So the most common presentation will be upper motor neuron. Okay, Dr. Hina will comment, then we will, but very good and very nice case, Dr. Mohammed. Please try to collect the idea from this scenario. Dr.
Yes,
Hina
yes.
will explain, and also I will give some comment after him. You can start, Dr. Hina.
All right. And thank you so much, Dr. Bazim, and thank you, Dr. Mohammed, for your time.
Okay,
Actually, it
thank
was
you.
a good presentation. You did very well. It was, you tried to follow orderly, but just that it's a little bit of you did I think you did reflect before the clonus, which was, to
Yeah.
me, it wasn't that I know, probably because this was not the exam, you are doing it online, so you just wanted to just get to the finish line. That is one of my comments here. And also, basically, you mentioned something like myopathy when you are talking about examination. I don't understand. I didn't hear it very well, but I thought I just like write it down that you mentioned myopathy. I don't know if that's true, but I heard you mention that. Then when this particular patient, like you did you mentioned that he came with a wheelchair, which was good. That was a good positive findings you mentioned. He had an orthotic there, which more likely an ankle foot orthosis that he had there close to his bed. Then you inspect for scar, which is very good. You did your general inspection. You look at everything. You check for the power, the tone, the power, and the reflex. This particular patient has the tone is normal, although sometimes in a case of, you may see hypertonia, you may see hypertonia, depending, but many times the tone might be normal or even hypertonia, depending. But typically, these patients also have the reflex here. The reflex is the reflex is absent in the ankle and the tendon and the knee, whilst there's an extensor plantar response, which is keeping with upper motor neuron lesion here. You also got the pes cavus, which is also another positive sign that you got, which is a good one too. Then looking at the whole thing, you also have the sensations where the anterior, what do you call it, spinothalamic tract is intact. Both the fine touch is also intact. However, there's dorsal column is affected. The posterior column is affected in this patient, and then he has cerebellar features too, the evidence of the huge chin abnormality that he had. Although you could not ascertain the gait, but assuming probably this patient was able to walk for you, you could have seen the wide base gait that he had, which is in keeping with what cerebellar, and the patient would have had a positive Wombeck sign, although that couldn't be done because of the patient condition. But like, I also appreciate the way you check for the diabetic, which is this glucose continuous glucose monitoring device in the hand, which is beautiful because they can have an association with diabetes, but not all patients, so which is good. Another thing that I did look out for, I did also talk about when you're investigating this patient, was the cardiovascular. You mentioned that. Yeah, you mentioned that. I remember you mentioned that, which is good. So that's a good point. You did that, which is also good. Then also you did mention neurophysiological study, EMG, and nerve functional study. Although we know that this is a problem with the central nervous system, no doubt. But based on the fact that there are some features that you are seeing here that's keeping with peripheral neuropathy too, you still have to also rule out other causes of peripheral neuropathy in this patient. Then also, we talk about genetics testing, which actually it is a autosomal recessive condition, and the gene that is implicated here is frataxin gene, basically. And like you mentioned, it's a trinucleotide repeat sequence, but does not undergo anticipation. Other conditions that are also trinucleotide repeat sequence, but undergo anticipation, are your Huntington's chorea, like you mentioned, Fragile X, myotonic dystrophy. They're all, they're all these ones that they are autosomal dominant. That's why they undergo anticipation. Whereas at the what do you call it? The Friedreich ataxia is autosomal recessive. That's why it doesn't undergo anticipation. Now, on that question I also asked too was, I think, which that question I asked, if I can't remember, in terms of, he did well for the management too, but he didn't mention MDT for management. That would have been also an additional thing that mentioned. MDT, very, very key. Also the occupational therapy, physiotherapy, and some other things like that. You have to mention how the role of each of them, including cardiology. Cardiologists, if there is any, heart abnormality, and then neurology, the counseling of the condition, follow up, and the rest of them. You should have mentioned that. Then I think basically, in case I'm not missing anything, I think I've said all the questions I asked. Thank you very much once again, Dr. Mohammed, and thank you, Dr. Bazil, for the opportunity. Thank you.
Yeah,
شكرا.
thank you, Dr. Nair. Well done. Thank you, Dr. Mohammed, as well. So the finding now, we can collect it together. To recap, the patient is having, let's start by, as we do usually, tone, power, reflex, coordination, sensation. The tone here was hypertonia in the knees and
No hypertonia.
no hypertonia.
Yeah. The tone was normal tone.
Okay, normal tone.
Mm.
The reflexes will be mixed. Okay.
Yeah.
So there is hyperreflexia at the knee level.
Hyperreflexia.
Yeah, and it will be hyporeflexia in the ankle level.
Also,
And
Dr. Henry told me hyporeflexia or abnormal reflexes.
The knee and ankle are hyporeflexia, while the plantar response, which is Babinski sign, is positive. Babinski is positive. Yeah.
So the Babinski here will be
positive.
Positive upgoing.
Upgoing, yes.
Upgoing. And this is the only situation in all cases you have to have lost ankle reflex with upgoing plantar. It's Friedreich ataxia. It's pathognomonic for Friedreich ataxia. Whenever you have this, you have to say the diagnosis of Friedreich ataxia. Okay, this is the only situation in PACEs. Maybe there is other neurological conditions. I am not sure, aware about it, but as PACEs, you have to say Friedreich ataxia on top of your differential. Let's continue the other finding. So the upgoing plantar, the sensation, as you see, it's mixed. Sometimes you have peripheral neuropathy, so you have the distribution of stocking, and you might have as well dorsal column affection, so you can have dissociative loss of sensation. Okay. Friedreich ataxia can present with any presentation: upper motor, lower motor, peripheral neuropathy, cerebellar, upgoing plantar. It's a cocktail of disease. Let's do the differential of other condition mimic the Friedreich ataxia. You said subacute combined degeneration, Dr. Muhammad. What again is subacute combined degeneration? What will be intact?
Cerebellar will intact.
Perfect. So you will have peripheral neuropathy, you will have dorsal column, but you will not have cerebellar positive or positive cerebellar. Okay. Let's do the next mimic will be
MS with peripheral
MS. Forget about, we are talking about the common and classical presentation. The MS, what would be presented with? The MS, upper motor neuron and
cerebellar.
And cerebellar with no peripheral neuropathy. So agree now.
And with posterior, doctor, yes?
Sorry?
And posterior column also, MS.
Yeah, dorsal column, yes. So let's repeat them again. All of them, dorsal column, peripheral neuropathy, cerebellum, and peripheral neuropathy. What will be? So all of them, cerebellar, dorsal column, peripheral neuropathy, and pyramidal weakness. Upper motor with lower motor will be Friedreich ataxia, yes. The other condition, multiple sclerosis. So you will have cerebellum, dorsal column, but no peripheral neuropathy, and upper motor neuron lesion, but no peripheral neuropathy.
Yes.
The subacute combined degeneration, you will put cerebellum, sorry, you remove cerebellum, and you will put peripheral neuropathy.
Yes.
Clear now, Dr. Muhammad?
Yes.
Yeah, so the all collection in Friedreich ataxia. Then you can play with the puzzle. You can remove the dorsal column from, you will remove the cerebellum from the subacute combined degeneration, and you will remove peripheral neuropathy from multiple sclerosis. Okay, it's very common presentation. And the best thing here to say while taking history, you have to specialize the history as family history. Family, I would like to take family history. Why? Because it's autosomal dominant. Sorry, autosomal recessive. So you said I would like to take history, but you can make it specific, more specific, family history, because there is inheritance or a genetic condition. The second point I want to comment on, you said myopathy. You said
No, isn't
myopathy.
Dr. Basim, at the beginning, I told the plantar reflex, and I saw the cerebellar. He told that the coordination he can't do because of weakness.
Yeah,
And
yeah,
there
yeah.
is no hypertonia at all. So this go with me. I forget the plantar at all. Once there is one upper motor there, I know.
Yeah.
Once hypertonia, hyperreflexia, colonus or upper plantar, خلاص, once enough to tell that it is upper.
Okay, perfect. So don't mention myopathy at all in this scenario. What else I want to comment on? Yes, the investigation. You are talking about multiple sclerosis, but as not as the common one. You have to say, in case of there is cerebellar affection, I could have this finding. But the most important rollout in the top of my definition, Friedreich ataxia. The investigation, as you and Dr. Henry mentioned, neurophysiological study, you can also roll out the complication like diabetes, as well as for the MRI. Vitamin B, it's mimic again, but it's not the case. You have to mention, but again, it's that. You have to say again, it's subacute combined degeneration if there is cerebellar syndrome. Okay. Again, the Romberg test, better to mention, as you said. I have to do Romberg test. I would like also to see his gait because it will help me to diagnose the patient. I will ask you now, what you think the gait will be?
Will be
Yes.
scissoring gait, waddling
You
gait,
have, you have,
waddling.
remember, you have peripheral neuropathy, right?
Yes, yes.
So it will be
There will be I think ataxic gait also.
high, yes, high steppage as peripheral neuropathy
And
plus,
ataxic.
yeah, could be ataxic gait because there is also cerebellar. That's why he told you he cannot walk. What about Romberg test? It will be positive or negative?
Positive, yes.
Yes,
Cerebral.
even while opening eyes, he might fall because he has cerebellar, right? Yes, thank you, Dr. Hamad. Dr. Hina, very, very nice case, and it always make you challenging and trying to think what are the finding and how to link each finding together to reach to the diagnosis. Any question
Thank
before
you.
moving? Yes. Yeah, thank you, Dr. Hina. Anyone want to comment or ask question? So we are ready to move? Dr. Hina,
Regarding
you ready?
Dr.
Yes.
Bess, please,
Yes.
could you make summary for this case for investigation workup?
Dr. Maro, okay. As you start with any investigation,
Okay,
basic
yeah.
investigation. Okay, Dr. Hina, you want to enumerate? Okay, you can.
The investigation, basically, you want to do your MRI, brain and spine in this patient.
Try to start with the lab investigation, blood test first.
Okay, the blood.
So
Yeah,
what
I want to
blood
do
test?
blood test.
Yeah,
Blood test.
yeah.
Basically, you want to do your vitamin E, vitamin B12, to rule out the subacute, because they can have this. They have similar
Okay.
mimic. You want to do your full blood counts and differentials, electrolyte, liver function test, kidney function test. These ones you want to do these ones first of all. They want to do random blood sugar because of the, and then
Perfect.
HbA1c. You want to rule that one out. Then you want to also do the bedside investigations, ECG for
Perfect.
the heart, any for prevention there's any AV heart abnormality or reading problem. Then also, you want to also do what do you call it?
Neurophysiological study.
Neurophysiological, such as EMG and nerve connection study. Then you want to
Perfect.
move ahead now to do the MRI of the brain and spinal cord. I think basically these are the core tests we need to do for this particular patient. Basically, if I'm not mistaken, I think that genetic study, that's the last one. With genetic study,
Yes.
that's the
I would
the
like
most
to
important one.
confirm
Yeah,
my diagnosis, Dr. Marwa, by doing
Genetic test.
genetic study.
exactly.
Yeah.
Okay, clear now?
Yes, Dr.
Always,
Clear.
try to start always with the basic. Don't mention all basics. Just say basic investigation. He will ask you, doctor, what do you think important here to do? You can say anemia or anything might be related, or you can
Yes.
skip directly to the specific test. What specific test here, as Dr. Henry mentioned? Vitamin B12 level.
Oh, yes, and vitamin
What
B12.
else? Bedside test, or you can say some chemistry or other kidney function to rule out diabetes, hemoglobin A1C, fasting blood sugar, and the bedside test in the form of urine dipstick, neurophysiological study, ECG, and echo if there is cardiac involvement. I would like to confirm my diagnosis by doing genetic testing. MRI also will show me some change or demyelination in the cerebellar or in the
Yes.
spinal cord.
Thank you.
Okay, thank you, doctor. Okay, neurophysiological study equal to nerve conduction. Exactly, yes. So neurophysiological study means both nerve conduction study and EMG. Both of them, they are doing bedside in the bed. Okay. So let's start Dr. Henry scenario. Be ready, Dr. Henry. I will share the
Okay, sir.
photo and the timer will start immediately. Any question, Dr. Muhammad, before moving to the next scenario?
Thank you, Dr. Bassem. Thank you, Dr. Ken. Very nice case and a challenge of really.
Yeah. Let's start. This is your patient, Dr. Henry, 50 years old, presented with balance problem, female patient. Look at the face, then proceed neurologically properly. This is the patient face. I will share, then I will start the timer straight away. I hope you can get some clues from the face. Here you go.
The face is not clear, but
Yeah, it's blurred like this, but try to.
I tried best
Okay.
for confidentiality. يعني
Oh, okay.
okay.
So he will
Okay.
describe for you what the patient is having.
Okay.
Yes, you can start now.
All right.
You can start and
Hello.
hello.
Hello. I'm Dr. Henry, one of the candidates of this exam. May I confirm your name and age?
Yes, Miss Mona, 50 years.
Okay. How was the voice as he's saying? Is the voice okay? How was the voice? Is it as she's responding? How was the voice? Was the voice good or normal voice?
Little affected nowadays, doctors.
Okay. Then okay. I want to. I've been asked to examine your face. Then proceed. May I please go ahead? Can I raise my hand? Okay. Then I look at the face. I appreciate the face. The face is there any drooling of the face? Any drooling? Any facial drooling?
What?
Mohammed, is any facial drooling? Any?
There is some
Your-
little deviation to the left side.
Okay. So then, okay. Then I look at the face very well. Then I will ask her, can you please look up? Let me check there. Any wrinkle of the forehead? Any wrinkle?
You will find some wrinkles on the right, not on the left.
Not on the left. Okay, thank you very much. On the right, wrrinkle on the right, not on the left.
The right,
okay, then
there is wrinkles.
all
The
right.
left.
Okay, can you close your eyes very tight and try to I want to pull it out. Can I? Any problem with it?
I can't close my left eye
Okay,
appropriately.
left eye. Okay. Therefore, can you show me your teeth? Clench your teeth for me.
Same.
Okay,
The
then
mouth
okay.
deviated little to the left.
It's deviated to the right. Okay.
Deviated
Then
to the left. Sorry.
to the right. Yeah.
To the right. Yes.
Okay. Thank you very much. And then I'll start. Then I'll look at the. Can you please show me your tongue? Let me see. The tongue is deviated. Okay. Fine. Okay. Then I look at the. From there, I'll start by proceeding. Then I want to look at the ear and examine the ear. Any vesicles in the ear? Any vesicles in the ear? No vesicles in the ear. In the ear. Any vesicle in the ear?
No.
Vesicles on the ear. Any vesicles on the ear?
Okay.
Skin rash.
Okay.
No,
Any scar in the parotid region? Any scar?
Yes, there is some scar behind the
close
ear.
to the ear. No, the hearing. No
Behind
scar.
the
Okay,
left
then I
ear.
want to. There's a
There
scar.
is a scar behind.
The left ear. Okay, behind the left ear. Okay, thank you very much.
Yes.
Then
there is
now,
small scar there.
okay. Then I want to look at check the hearing. Ask him to, speak to him in the left ear. 1, 2, 3. Can you understand? Can she understand?
Again, till again. I can't hear well on the
The
left
right ear.
side.
1, 2, 3. Does she? Can she?
Right ear, right
Okay, she
ear.
can't hear on the left side. Okay, right she can hear, but left she cannot hear very well. Okay, then I go ahead. Since she cannot hear, then I want to go ahead and do my web runnings test.
Yes.
I pick the 512 turning fork. I show you this is a turning fork. I want to put it on your on your bone, on the back of your ear, the bone there.
Yes,
Then I strike.
yes.
If you feel it, let me say yes until you stop feeling it. Then I strike it. I put it in the
I feel it. I feel it. I feel it.
You
But
feel it.
somehow
Okay.
why
Then
I
then
didn't.
okay. Then let me know when you stop hearing it. Have you stopped hearing it? Then put it in
No,
the
I
air.
stopped hearing it. I stopped
Okay.
feeling
Then
it.
okay. Then I put it in the ear, in the air.
I can't hear it.
You can hear
I
it. Okay.
can't hear it.
Beautiful. I do the same thing in the right side. Is it the right side? Air and bone conduction. Air is better than bone conduction in the right, right?
The right is okay. Nothing in the right.
That's okay. Okay. Then after I've done with that, I now probably take the turning fork and put it on the forehead. I ask you where does he hear it most? Is it on that ear? Or is it which ear does he hear it most? Or is it centrally, or hear it on that ear? On the other ear? I want to
can't
confirm
understand the vocabulary. I can't understand.
the web test. After I do the renal test, I have to go and do the web test to confirm where the lesion is. If it's a what do you call it? If the lesion is okay, it's okay. Okay, I understand what you're saying. Then from there,
you do the Rene test. It is sensory neural loss on the left side. Okay.
Okay. Then I move ahead and can you please show me your tongue, please? Show me your tongue.
The tongue.
Okay. Say ah.
Yes. Yes.
Any problem with the uvula?
Yes, there is.
Then okay. Then I
1 minute left.
ask him to cough. Can you cough for me? Okay. Then can you please show bring out use your tongue to push my hand, check for the 12, the cranial of 12, and see if the cranial of 12, which is the apoglossal, the tongue is any problem with the tongue? No problem with the tongue. Then
The tongue is okay.
okay. Then I check for the cranial of 11 by the trapezius, try to compress and see, push my hand is okay. Then I want to do okay. Then I want to do this. I want to just quickly do the facial nerve V1 and V1, V2, V3. Any sensation loss? V1, V2, V3. Any sensation loss? Okay, there's sensation loss. Okay, then I thank my then I basically look at, then thank my patient, and then raise my hand and face my examiner. Okay.
You don't want to examine any upper limb? Or?
Okay, yes, I want to do pronotal, any pronotal drift.
Pronotal drift?
Yeah.
Yes, there is both limb is weak, more on the right side.
More on the right side. Okay, then okay, so more on the right side. Okay, then I check the reflexes. Reflexes is up, down or up?
No, reflexes is a little hyper reflexia.
Okay, all right. Thank you very much. Thank you.
Okay, time is up. You can start now, Dr. Mohammed, the questions.
Okay.
Yes, Dr. Basim, I need him to complete the sensation.
Okay, continue. 1 more minute.
1 minute.
Okay, the sensation, what is the sensation like? Is it the sensation level? Is it I put my pin, both pin and cotton wool? Any problem? Any problem with the sensation?
I can't feel at all in the right arm.
Can't feel at all in the right side.
Yes,
okay.
I can't left. I can't feel the pain.
Okay. All right.
Still continuous sensation.
Okay, then they use the what they call dorsal column. They check for the vibration and proprioception. Anything?
It is okay in my right hand. Left, I can't feel. Up.
Left, can't feel.
I can't feel.
Okay. All right. Okay. Thank you very much. Okay.
Difficult, Dr. Hina.
Yeah.
But you will catch the clue, and you catch the
Okay,
primary.
sir. Okay, sir. Okay, sir.
Me, what
Okay,
is
I think.
your positive finding?
Okay. I've examined this gentlewoman who on general examination there's facial drooping, which was there's a scar I noticed in the left side of the ear, and also there's there's right facial nerve, there's left facial nerve palsy, there's impaired hearing in the there's impaired hearing as evidenced by impaired hearing in the left side, and also the facial nerve, the kind of five there's lots of sensation in V1 and V2 area, and then there's right pyramidal weakness with hyperreflexia, with hyperreflexia, and the senses and there's a loss of pinprick and fine touch in the left side, whereas in the right side they are intact. So looking at my whole findings, most likely the patient, by differential diagnosis in this case, would be a complex neurological disorder. Most likely, one, I'm thinking that the patient has a CP angle tumor that's affecting the left side.
Yes.
And then, yeah, CP angle tumor affecting the left side. Then there are other different. Yeah.
Excellent. Continue.
The other differential diagnosis I want to consider in this case too could be, multiple sclerosis. However, because of I think then trauma, it could be multiple trauma too. That affects both the multiple traumatic injury that presents more likely to having features in keeping with Brown-Sequard syndrome too in the upper limb. But no, I think I better just go with my CP angle tumor. Thank you.
It's excellent, doctor. What is your investigation?
Thank you. My investigation, I want to start by doing baseline full blood count differentials and liver function test. Then I want to do kidney function test also. Then I want to do blood tests to check for other vitamin. I want to do ECG, to confirm my diagnosis. I want to do brain MRI, brain and spine MRI, to rule out any tumor, CP angle tumor. Then also in this case too, I want to do what else? I think basically these are the tests I want to do for my patient, basically.
Yeah. And you mentioned MS. You will not do LB for him?
Yes, I want to do a lumbar puncture test to check for oligoclonal band, and then visual evoked potential. Then I want to do also in MRI. I expect to see the dancing finger and multiple time and space lesions in the brain MRI. Thank you.
What is your management?
Management of these patients will include a multidisciplinary approach, which involve the neurology, the occupational therapy, the physiotherapy, specialized nurse, and the radiologist. Also, the psychologist and then psychologists also be involved in this patient. Our patient will be checked by the neurologist, in which there will be, and then neurosurgeons will also be involved in this case. The definitive management in this patient, if it's CP angle tumor, that is the likely diagnosis will be surgery, in which there will be surgery, and then following that, there may be also need to perform radiotherapy if need be, if there's any remnant tumor after following excision of the tumor. And then as part of the medical management, also we need to, the non-pharmacological management, we need to start physiotherapy. Then there's any spastic, we need to, and patient may benefit from antispastic agents such as baclofen, and then basically counsel the patient of disease condition and follow up, and multiple follow up and routine investigation to monitor the patient. Thank you.
Yes. What about this scar, Dr. Henry?
Okay, the scar behind the ear, right? Yeah, the other difference. Yeah, this scar could be, maybe it could be an access for it could also be a cause of the, it could be a cause of the maybe an access scar for surgery that he has had previous surgery.
Okay, thank you, Dr. Henry. Excellent. You bring the primary diagnosis for the case. Dr. Bassem, you comment, or you will comment first?
No, my question was about the scar, but you asked it. This is the pathology. You missed the pathology.
He should comment on the scar. He should tell already the
Yes,
patient done the surgery.
and this is the cause. How you
Yes,
miss the
yes.
cause?
Yes, yeah. This is the cause and the treatment at the same time.
Yeah, already done. Yes, okay.
Yes.
So you can comment, Dr. Muhammad, then I will comment.
Dr. Henry, look, this case والله يعني I didn't bring it. I found it as a real on internet. It is not a common, تمام? But it is a common as a CB angle, and you bring it, تمام? We have 7 cranial nerve and 8 cranial nerve. This clear in front of you. And this when you mention this 5 cranial nerve, I mentioned there is some sensory for the patient. It was a complication of the surgery that done. There is some injury also. And usually when you did, he will tell you proceed neurologically, and they tell you look at the face. It will not be a face only. This is usually, and it will not be a face only. Usually there was some complication or something behind, yeah. So you didn't notice at all or comment at all about that dissociated sensory loss, about the anterior column on the right side and dorsal column on the left side. And this is very characteristic for syringomyelia. The scenario of this case that she has schwannoma compressing after they were treated conservatively, but after there is sensory loss and balance becomes severe, there is compression on the canal and have this syringomyelia. So they did the surgery for him for the CB angle tumor, complicated by this 5 cranial nerve injury. So you did well, mashallah. You put the first the primary diagnosis for the patient. But my comment only, don't concentrate only on what the doctor or the comment or the question itself. Should be a generalized neuro. You can continue and see his cerebellar symptoms. Yeah, you didn't even see his cerebellar, maybe affected also with the patient. And you did well طبعا at the beginning. You check his speech, and you should shake his hand to see maybe myotonic dystrophy, maybe by the clinical in front of you if you suspect. You did well for the also checking the fatigability of the eye by looking up and see the creases of the face. Then you have 2 routes for this patient. You will confirm it is CBA angle, and I will continue to check other neurodeficit in his body, like cerebellar, like this. Even the nystagmus, the eye movement, you didn't check. You can check cerebellar even from the face. Or it will be clinical diagnosis straightforward from the face, but usually it is not common like this. Other the investigation, it is the same. You will do the most important طبعا, apart from the basic, you will do MRI brain, MRI spine, LB. LB is very important also for syringomyelia. They diagnose from the pressure. They diagnose also other differential like MS like this. And the treatment, it usually urgent decompression by the surgery with the multidisciplinary team, physiotherapy and like this. And usually these patients, another clue you will find during your examination, his upper arm, you will find in the site of where the anterior column loss, mini burn there. He is not sensing at all any temperature or pain. So when you examine, you will find this. I was about to search a picture for it. But usually we found the patient has many burn on his side because he don't feel at all this side. Thank you, Dr. Henry.
Thank you, Dr. Muhammad. Thank you.
Yeah. Thank you, Dr. Muhammad, for the comment, and well done, Dr. Henry. The most important, and you did on this scenario, the inspection, and you inspect the scar.
Yeah.
However, you didn't mention it, but you present the finding well. So you can get the good mark regarding the finding. However, you miss the scar, but still the presentation as cerebellopontine syndrome or angle tumor syndrome. So you have 5th and 8th and 7th cranial nerve affection, right?
Yes, sir.
Along with the other also lower cranial nerves like 9 and 10, vagus and the vagus number 10, and the 9 I think it wasn't affected, right?
No, it
Bliss?
wasn't.
Not affected. It is 5, 7, 8.
Yeah.
5, 7, 8 only. Okay, but it might extend down
It can extend.
sorry.
Yes, can extend according to
Yeah, it can
how much
extend.
the
Yes,
tumor
yes.
is.
Yeah, so it's good to catch it. As Dr. Muhammad said, it's difficult scenario, but don't forget the cerebellar. Cerebellar mostly will be affected because, as the mentioned in the name, cerebellopontine angle tumor. So the cerebellar will be affected.
And maybe this is cause the decrease of the
Balance.
Yes, يعني. Yes, it's very يعني in front of him he can do nystagmus, can do any test for cerebellar.
Yes, exactly. So you did already the eye examination, the H shape. So you can catch the finding by doing the H shape. Add to them coordination. The hand, for example, or intention tremor, or the speech. You asked good question initially. Tell your name, the speech, and he said, I don't remember what Dr. Muhammad mentioned, but supposed to be Dr. Henry. What the speech of cerebellar syndrome?
Scanning and psychotic speech.
Yes, staccato or scanning speech. Yes. So the sound will be up and down. Okay. What else? So Danish. Remember Danish.
Yes.
Dysdiadokinesia for the clapping of the hand, and A for ataxia. So you can also offer the gait, and the patient will be ataxic. N for nystagmus.
Nystagmus.
I for intention tremor.
Yes, tremor.
S for staccato speech.
Yeah.
And H for
hypotonia.
Hypotonia. Perfect. But if, as Dr. Muhammad mentioned, at least, because you will not have time to do the cerebellar plus the cranial nerves as you did exactly. So at least one of them, or one of them will be included in the eye examination, which is the nystagmus. So you will find the patient is having a nystagmus. Then the scar. Whenever you mention or whenever you discover it and you point to it by your finger, you show the examiner that you catch the scar. Even if you miss it later on, at least you show him that you catch it. But try to put it in your differential or in your presentation. So I noticed there is a scar behind the right ear, for example. What other pathology could be? As you said, yes, multiple sclerosis as upper motor neuron lesion, tumor, trauma. All of them can affect this area, and it might leave this finding or presentation and manifestation. I think, yeah, it's a good case. Really, both scenarios today, very unique cases, as Friedreich ataxia and cerebellopontine angle tumor or angle lesion or whatever. The manifestation, as we mentioned. So the 5th nerve will be the sensation over the face, right? The distribution of trigeminal nerve. The 7th nerve, how to do the 7th nerve examination, Dr. Henry?
Yes, sir. 7th nerve.
7th,
yeah.
The facial nerve.
Facial nerve, okay. I'll start by looking at the face, seeing if there's then something from head to toe. Ask him to look up, and see if there's any blinking. If there's shrink, if there's then look for the wrinkles to look. If there's wrinkles, if the wrinkles are intact, if there is then most likely it's upper motor neuron disease because upper spare upper.
Yeah.
But if they are affected, most likely are dealing with lower motor neuron. Then we look at the eyes. Then ask him to close his eye very tight and see if there's any. Then go to the cheek. Ask him to clench his teeth.
So
Then,
simply 5th nerve for the sensation, seventh or the facial nerve for the power. Agree for that?
Yes. Yes,
So
sir.
the sensation
yeah.
mostly by the fifth, the power will be. So the power, you ask him to tightly close his eyes, to raise his eyebrow up, to smile, show me your teeth, blow, whispering.
Blue, yeah.
Yeah. So all this this will show you the finding of deviation, and you can catch it from the power itself. Okay. Then the tongue and the uvula for the lower cranial nerve, 9 and 10 and 11. It wouldn't be in this scenario anyway. I think these are the findings in our scenario today. Well done, Dr. Henry and Dr. Muhammad. Anyone want to comment or to ask?
Yes, Dr.
Yes.
Bassem.
Yes,
I
Dr.
will.
Muhammad. Yeah.
This case, really very difficult case. But
Yeah.
you know, Dr. Bassem, one of my colleagues, she did examination in Alex Center. This
Okay.
time, the case was like that exactly, and many of them they went out from the station and they didn't decide what is the diagnosis exactly. She told me that the finding that the patient was examination of the upper limb. Then she started typically by tone power reflexes. She found that the patient having hypotonia. There is weakness more distal than proximal. Then there is the associated sensory loss. Okay, like you mentioned also in this case. And then in the face also there is a loss of sensation, and there is positive lower motor neuron facial bilateral and the trigeminal also loss of sensation on the face. So many people they were different regarding the reflex. Some people they told that there was mixed. There is one reflex was lost. I think biceps, and there is triceps reflex. So some people thought of cervical myelopathy, but I think the diagnosis is near to syringomyelia. This is my impression.
Oh, very difficult scenario.
Well,
Syringomyelia will
here,
be.
Dr. Bassem, I heard. I don't know
Yeah.
that this is the case, really. This is the case. I do it not by any resource. Yani. It is not by any.
Very, very
But
difficult case. I think
one
Yes.
one element of this case that the motor system for the syringomyelia, it is not coming like upper motor or lower motor. Sometimes started at the beginning if the mass of the
Yes. The
TBA tumor is
herniation.
very
Yeah.
small, yes, it will be very normal, nothing. It will be very normal. But by the time, if the patient not go to manage it, it will become like upper motor after that. It will be like cervical myelopathy. And I heard about Alex's case. Many of them told cervical myelopathy, but they were not sure.
I
So
think it's not
maybe
like
this is the case here.
by the finding, it looks like your case exactly, doctor. Because you know there is distal muscle weakness more in the hand. Then there is hypotonia and
Not
the
only
reflex.
weakness, Dr. Marwa, you will have also wasting. Weakness and wasting.
Yes, she told me
Yeah.
that, but more
Yeah.
distal than proximal. Then she
Yeah.
thought of first of stroke because there is loss of sensation. But what make her confused that there was lower motor neuron facial and loss of also over the trigeminal and associated sensory loss. So I think a very difficult case, really
No,
complicated.
it's unfair to bring it as both or all finding and discover the case. We are not a neurologist. What you can do or what they can bring, like upper the hand examination. So it's easy to catch it as upper motor mixed with the lower motor. As we know, the biceps will be hyper or sorry hypo or loss reflex in the biceps.
Biceps hypo, triceps hypo. Yes.
Exactly. Yeah. So yeah. So at the level will be lower motor, and below the level will be upper motor neuron. Supposed to
And
come like this, but to
But
bring the
dissociated
face.
loss are the better. Dissociated loss, it is
facial.
mnemonic for syringomyelia. It should be
You,
put at least at the end of the.
it's difficult to think about it in the exam situation, unless you are prepared for it. Whenever you
Yes,
practice it, yeah, which is
yes.
difficult for first time in the exam.
So I saw that you brought the case from the Alex Center, but you told me.
No, والله this is by my imagination and I
It's
see it
okay.
in the
At least we know it.
Exactly.
At least we know it, and we know the center can bring it, which is Alex. I don't think in all the world they don't have this case. Maybe it will be there, but it's not common. Again, what will be lost in the sensation in cervical myelopathy or syringomyelia? Let's say syringomyelia first. What is the most characteristic sensory loss in syringomyelia?
اللي هو dissociated sensory loss, yes. يعني it will be
Yeah,
there-
it's cape-like distribution, cape-like.
yes. And also there were
The pain and temperature. The
and
pain
touch. Yes,
Yeah.
touch will be.
Okay, touch nothing. He is the patient is basagnomic. He is have always he not feel the pain and temperature. in his right-
Exactly. Yeah, and the finding and the symptom or the patient can present with touch or burn everywhere.
Yes, burn everywhere.
And
This is
wound,
common.
yeah.
This is common.
Yeah.
Yes.
With
You
the
know,
time, yes.
there was also very يعني she told me also that the funny in this matter that she examined before in Alex. This is the second time she tried to apply for Kairos and again Alex. Then she told me this time also the same. The patient was not cooperative at all, and she was a little bit, want to sleep. I don't know. She
Yeah.
told me confused. She didn't. She was not cooperative. So the sensation also with the patient not cooperative, it will be very difficult to assess.
Yes, of course. Yes.
And then the examiner tell her, try to take any information. We will appreciate that.
I hope they will be fair in the marking also, not only with the talk. Some
She
examiner,
will-
yes, okay, do, but when he put the mark, he will minus a lot. So what
told me- she told
what's the
me
benefit?
she told
Okay.
me want to put for me the identifying physical sign because her physical sign was okay, but differential diagnosis she didn't tell. She told him stroke, so I think away from the diagnosis.
Yes, it's not stroke. Stroke will not present with lower motor.
Yes.
Okay, so the only case will be syringomyelia, as we discussed. Anyway, just to learn it, it's a good session. Thank you, Dr. Marwa, also for sharing this case because it's a very rare case, but it comes now. So everyone preparing for next diet to Alexandria Center to be ready about this case. It will come definitely, okay? Because they brought it once. Once they brought it once, they will bring it again and again.
Yes.
Thank you, Dr. Marwa, again. Thank you, Dr. Hina and Dr. Muhammad. Anyone want to comment or question? Anyone want to comment? It's very informative session. Thank you, Dr. Muhammad and Dr. Henry. And both of them did perfect. Yeah, and the question also was great. The discussion was informative. I hope all of you will enjoy this session. Thank you, Dr. Marwa, also for the experience and practicing with us. Thank you, everyone, for the attendance. Any question before ending the session? So I will wish all of you, thank you, Dr. Ihda. Wish all of you very happy weekend. See you, inshallah, after the weekend. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Okay.